This talk is 0 to 1, the golden age of stroke care. The reason I titled it 0 to 1 is because in the last decade we've made a progress in stroke that is more than just n+1 or an addition or an iteration or even an incremental change from what we've been doing in the past, but really a fundamental difference in whether we treat stroke care, patients with stroke, from a surgical or endovascular standpoint. As I mentioned a decade ago, stroke was a very difficult disease to treat, but certainly the burden of stroke throughout the U.S. was high and increasing over time based on CDC data. And at the time, over a decade ago, we had very few options for patients who had stroke and even less options for patients who had large vessel stroke, and we'll talk about that a bit later. IV TPA, the clot buster that you hear on TV, was the best drug that we had on the market based on our literature and data. The data showed that giving it within a certain period of time, 4.5 hours of symptom onset from the start of the stroke, led to a better outcome than other medical management at the time. Also at the time, endovascular pioneers were trying to pull out clot with balloons, macerate clot with wires, threading catheters past clots. They were doing all sorts of things they could do in very rare instances where TPA or that clot buster had failed and the patient was going to get worse, and there was a real risk of mortality for the patient or incredible disability. But even with our best data, if you combine our best data, the IV TPA or clot buster was at best good 40% of the time. That was a decade ago. Ischemic stroke has come a long way in terms of our perception and understanding. Not all strokes are the same. And what has happened in our literature in the last couple of years is that we have focused on large vessel ischemia or large vessel occlusions. The reason being is that for certain types of stroke, especially those involve the biggest vessels, the middle cerebral artery, the internal carotid artery, there seems to be a very bad prognosis if that clot does not dissolve immediately. Now, for the small vessel strokes or small blood vessels where clots can form, IV TPA can be very, very useful. But for these large clots, that's where the failure of TPA has been noted, and that's where endovascular therapy has kind of shone in the last 5 years. And this is what we mean by large vessel occlusion. So this is an angiogram of a patient a couple of weeks ago, and this patient presented with, and this is you looking at the patient. So this is the right side of the brain, this is the left side of the brain, and this is an image with the skull in it. We shut the lights up in the back where you can see better. And when we do an angiogram, we see that the blood has come up the internal carotid artery, and the internal carotid artery divides into the anterior cerebral artery and the middle cerebral artery, and there's a clear cutoff here. If you imagine the middle cerebral artery having a large candelabra or blood vessels here, they're all missing. And this is what we were facing as a challenge, therapeutic challenge. And before, as I mentioned a decade ago, for this kind of severe disease, all we had was the IV medication to bust the clot. And even then, we can only use that IV medication if you're caught within 4.5 hours of your stroke. So imagine being at a very rural site and not being able to get to the hospital in time, not recognizing the signs and symptoms of stroke before it's too late. All of these things made a difference whether or not a patient was able to get the medication and do well from it. I want to talk a little bit about a history, and I had mentioned earlier that surgeons, radiologists, neurologists had all been trying to figure out ways from an endovascular standpoint to break up the clot. We knew that this was a bad disease at the time. We knew that we had to do something. At the time, we only had very limited technology. Companies were skittish about doing a lot with the cerebral vasculature. The cerebral vasculature is not like the cardiac vasculature, and bad things that happen in the cardiac literature don't lead to bad significant consequences, but in the brain, severe strokes, hemorrhages, dissections, damage to blood vessels, these can all be worrying things. And so the devices that we were using at the time were either too soft or too sensitive. These 3 trials, Synthesis, IMS3, and Mr. Rescue, You're going to see a lot of trial names today. They all have fancy names, but I don't want to go through the details specifically of each trial and bore you to death. But I will say that these 3 trials showed no benefit of using endovascular therapy for the treatment of large vessel strokes. So these 3 trials show that at best, IV TPA alone was just as good as if you tried to do anything you could from an endovascular standpoint. These 3 trials also included people putting a catheter into the brain and injecting IV TPA directly onto the clot. These 2 devices that you see here were the 2 devices that were mainly used in these trials. One is called the Mercy device, and the other is called the penumbra aspiration catheter, and both were ways to try to break up clot. The Mercy device is the one that's here on the left, was basically a corkscrew mechanism with a bunch of filaments on it. The idea of trying to entrap a clot with those filaments and pulling it out. And the penumbra aspiration catheter is basically just a big vacuum cleaner that you stick up there. There's a device at the end of it, the purple thing, that you use to, again, macerate the clot and attempt to take it out. What was interesting is that some of these trials did actually use a stent to try to pull out the clot. But as you can see, the percentage of patients who actually underwent that type of therapy were very low in these trials. And as I said, these trials kind of put a very big damper on the endovascular world in terms of what they could do for the treatment of stroke. And just to review, because we're going to talk about a few things, a few grading scales during the talk, one of the most important grading scales that we use in stroke is the modified Rankin score. Now, it's not a perfect scale, but what's important to know is that the score between 0 and 2 is actually classified as a relatively good outcome, and is the outcome of desire when looking at trials. So going forward, as you think about the trials and as we go through the talk, we're going to be referring to modified Rankin grade scores between 0 and 2 as being favorable, and anything higher than that being bad. And some people even clump 5 and 6 together because the severity of the disability and death is almost comparable in terms of the level of outcome. We all know time is brain, and I keep wanting to put this slide up every time I do a stroke talk, but just to remind people how sensitive our neurons are to the loss of oxygen and the loss of metabolic control. And what's interesting is I like the last column here with the accelerated aging. So per second, you're putting in another couple of hours of your life at risk. But if you have a true stroke with 1.2 billion neurons lost, it can add 36 years to your accelerated age. And so every minute counts. This is a famous slide that's been out in literature for a number of years now. But again, just to reiterate, a patient coming with a stroke, with a suspected stroke coming to the emergency room, and this is the importance of the pre-hospital triage in understanding what the symptoms of a stroke are. As time moves along, the likelihood that the patient is going to have any functional independence at the end of their hospital stay, no matter what happens, continues to decline with time. So it's the recognition of stroke and the timing that really counts in these cases. Strokes, I like to think of them as nuclear bombs. The center of a stroke is ground zero, and then you have the fallout zone, which has been referred to as penumbra, and you'll see that in literature too and during this talk. At ground zero, at the nucleus of a stroke, the brain does not have enough oxygen to sustain the neurons at any function. And with enough time, there's even genetic changes with the area around that around that initial stroke area or focal fallout region, and that is the penumbra. And we know over time that penumbra expands to encompass the entire volume of a stroke. So let's say you have a stroke. This would be ground zero. So this is the brain that's already died, does not have any blood. The yellow is all the brain that has less oxygen getting to it via blood supply. But as the brain loses its ability to compensate for the amount of oxygen it can supply to this part of the brain, the size of the stroke continues to increase in size. And what we are trying to do, in neuroscience, is we know that the ground zero region is dead. We can't do anything about it. But it's the penumbra which we can try to hopefully save in these patients. Another review issue, there's been a lot of debate in the last 5 or 6 years about what is the best imaging for stroke. And even at this institution, it has gone from using an MRI scan, using CT perfusion scans, using different types of vascular imaging, and has gone the other way and using even the most minimal type of imaging is a plain CT. The Alberta Stroke Program Early CT Score, or the ASPECT score, has been used widely and has been an ideal imaging modality as a CT scan since it's very available in the community, and using this score to identify what areas are at risk. Now, what people do is they get a CT scan of the brain. You look for areas of hypodensity or areas where the brain is dark, meaning that part of the brain may have died, and there's a scoring system based on what has died at the basal ganglia level, either at the insula, the internal capsule, the caudate nucleus, and the lenticular nucleus, the putamen. Depending on what parts of the brain are hypodense or dying or dead, you can give that a scoring system. Now, the scores vary up to a grade of 10, and everyone starts at a grade of 10, and you lose points for parts of the brain that have been lost. And this scoring system has been used in all the trials recently and has been very useful, and we have kind of used that system here to a certain extent as in our stroke processes, because time is brain, and so getting a patient from wherever they are to our endovascular suite, that timing is very important, and so we've used this grading scale to help us out a lot. Well, in 2015, to fast forward a little bit, 5 major trials came out which actually showed a benefit for endovascular therapy. Now, I'll go through each of these trials individually, but the bottom line is that these trials were using stents or stent retrievers, and I'll talk about what those are, as opposed to the other devices that we saw. And so 5 clinical trials, Mr. Clean, Extend IA, Escape, Revascat, and Swift Prime, all came out. The trial started in 2010 and the last one ended in 2015, but the actual publications all came out in early 2015. And what was amazing is that they actually showed a benefit for the first time for endovascular therapy. Now, the benefit was reflected in that modified ranking scale, and I'll blow up the middle image more. Endovascular versus medical therapy, and for each of the trials, the percentage of patients who had a beneficial modified ranking score at 90 days or 3 months was higher in the treatment group, the endovascular treatment group, versus the medical group or medical arm. Well, why were the results so amazing? Well, I'll skip back to that slide in a minute. Well, why were the results so amazing? Well, the stent retriever was basically the major portion of these trials. Now, what is a stent retriever? The stent retriever is unlike the devices that I had just shown you, which were aspiration or a vacuum cleaner or a set of wires to pull out a clot. A stent retriever is a stent, essentially, that entraps a clot against the blood vessel wall and maintains blood flow during that period of time where you're actually deploying the stent. Now, they first tried this in Europe. Like all crazy Europeans, they tried something new, and at the time, I think about 8 years ago, the first guy decided to partially deploy a stent in the blood vessel to try to take it out. This is when people are desperate to try to use something. People are using microwires, things like that, and catheters to poke these clots. And one gentleman decided to partially deploy a stent and pull that out, and that became big news. And then there was a run by many companies in the United States to patent these devices. And ever since then, we've had a flood of devices in the market. The 3 main ones in the U.S. are the Solitaire, the Revive, and the Trevo. And these are just demonstrated here, but essentially they look like a stent. They act like a stent, but they don't detach when you release them. And the idea is that they push the clot on the edge of the blood vessel, and you can see that the clot stays on the outer surface of these stents, and you just pull them out. And so when you see the stent at the end of your procedure, you just have what you hope to be clot on the outside and no clot on the brain. And these are the 3 different types of stent retriever you can find on the market. They're very, very similar in appearance. They're essentially just stents that you can retrieve. Going back a little bit, those 5 trials, just to summarize what those trials did, I like to think of data as being easily interpretable, and I think that the number needed to treat is one of the easiest ways to understand if the data shows that there's a benefit. And for these trials, if you combine them, you only have to treat two and a half patients essentially to find benefit for added benefit for doing endovascular therapy, which is an excellent number for a surgical trial. What was also interesting about combining all the data for these trials is that we always think that patients 80, let's not do anything. I mean, you'll have to die of something, right? So, that was one of the common misnomers or misbeliefs prior to understanding this aspect of stroke, and that it's very reasonable to treat patients well into their 80s and 90s. I think we treated a patient who was 99 a month ago. But one of the things that we have to avoid is ageism, because we're all going to get to that point, especially the baby boomers in this era. What was also interesting is that patients who had endovascular therapy benefited even if they were at that endpoint, at the 6-hour endpoint of their since the start of the onset of the stroke, which is an interesting threw out an interesting question. Should we, expand the window when we treat these patients? Before, we're trying to get these patients into the endovascular suite within 6 hours, but could we lengthen that? And we'll come back to that question later. And in terms of the aspect score, I talked about that score. You start off with a perfect score of 10, and you get points deducted for every hypodensity or stroke in those basoganglia parts of your brain, or even the cortical areas of your brain. And what these trials showed, that if you have someone who comes with a CT who has an aspect score of 6 or less, it's not, or sorry, I should say less than 6, it's not any real benefit for endovascular therapy, which will help guide therapy. So I talked about these trials and iterations of these trials. So ever since these trials came out, and these are the trials here that I've referenced, there is a mathematical puzzle called the Seven Bridges of Königsberg, and Euler, back in the day, tried to challenge people and say, how could you cross each bridge without having to cross it again, and challenged people to make a mathematical formula to figure that out. Similarly to these trials, there is no attempt to cross over. But what was amazing that all these trials decided to come out in 2015, and ever since then, each trial has to either recapitulated the same results in some form of fashion, and each other newest trial has tried to add something to the data. Right now, we have trials that are trying to look at lengthening the time window. We have trials that are looking at different types of catheter or different types of stent retriever. So here's an example of what we were facing. I'd shown you that image at the beginning of the talk. Here's a patient who has the internal carotid artery, like we had seen before. This is a different patient than I showed you. There's a cutoff sign. There's no blood flow going to this part of the brain, the right side of the brain. The endovascular artery is still working pretty well. And this is a 49-year-old guy, so like at least half of us in the room. The pre-stroke modified Rankin scale was 0, so he was totally fine. His last known normal was 3 hours ago, and his aspect score was 8. And I had mentioned a bit about that just a slide ago. The procedure was performed. We were able to get a catheter up there, and the stent was able to plug the clot. And here's a centimeter rule to show you the comparison of the sizes. So, our blood vessels are probably like 2 or 3 millimeters in diameter. 2 or 3 millimeters in diameter, and you have a clot and a stent retriever that's about 4 millimeters in diameter pulling out that clot. And that's the result afterwards, where you have the blood flow restored to the middle artery passed beyond the region of that occlusion. And then you have a very happy fellow who's like, I saved a life today. This is Dr. Monteith's case, so he's the other guy in this photo. The one thing I want to talk about as well is the Ticky's grading score, and you've probably heard that in the literature a little bit, or in how we define these. So when I look at an image like this, I want to get to the point where we're here, where all the blood vessels are open beyond the area of the occlusion. But what if they're not? So there's a grading scale that came up for people who had partial success for their thrombectomy, because not all thrombectomies, not all endovascular therapy works perfectly every time. And when we define a good result, just like the modified ranking scale, we look for a result where at least half the vessels or more have blood flow back into them as they did before the surgery or before their premorbid state. So that's a grade 2 or 3. 3 is perfect, like every blood vessel that is open like it should have been. Grade 2B is that greater than 50% of those vessels are open. And anything below that is considered not as good, or even a failure if there's a grade 0 and no perfusion. You've tried your best to pull out the clot and nothing's happened. And that certainly does happen, and this grading scale helps us categorize the success of our procedures. This slide took me forever to make. That's why I'm going to show it. I'm looking for a very long time. So I talked about Mr. Rescue and IMS3, if you remember from the first couple of slides. Then we had those 5 trials that came beyond that, and I've differentiated with that red line. So this is the pre-stent retriever, and that's the green use. There's very little use of stent retrievers in those trials, and then a sudden boom in the use of the stent retrievers after that. What also happened is the quality of our TICI score, that grading scale I just showed you, how good that was after a procedure, endovascular procedure, and how good our modified ranking scale was. And if you notice that with the trials, our modified ranking score improved over time, and so did our TICI score. But, and this is why I made this slide, is there is a huge difference. No matter how good our pitches look, no matter how good our TICI score or endovascular score looks, there is a disparity between our modified ranking scale. So it doesn't matter if you make the pitches look perfect, you still are not getting the patients perfect, even with a perfect imaging result. And so I think it's very important to realize that we can continue making better devices, we can continue trying to make our images look better, but it has not reflected the quality of the outcome. And so there's a therapeutic gap. And that's the therapeutic gap that and that's why I titled this talk, The Golden Age of Stroke Care. This is where we can make our improvements. This is where we can change the course of these patients' care. How do we do it? So it's not all the device and it's not all the drugs that we use. There are other factors that play into how well a patient does. One of the biggest things that has happened since I started going from a fellow to faculty here is our systems of care have kind of changed. We became a comprehensive stroke center my first year here, and that has changed the way we do stroke care, and that's also changed the way that patients have been referred to our center for expertise in this field. One thing that has historically been very successful in the era of just IVTPA was the hub and spoke model. You have a hospital that's at the center of a large spiderweb network, and you have other smaller hospitals that can all provide IVTPA and then transfer the patients to the main hospital for further stroke care. That works great for that system when IVTPA was the only thing that we had. The other thing that we have evolved over time is that you've seen all the posters in the hospital about FAST. I'm sure you've seen them, and they all, help you screen for whether a patient has stroke. Face, arm, speech, and time, and they help you just, try to figure out, okay, does the patient have a stroke or not? Great. We have to come a step further now, because we're talking about large vessel occlusions, and large vessel occlusions are the patients who are going to benefit from endovascular therapy over just medical therapy alone. So we're using a Los Angeles motor scale now, or trying to transition to it in the EMS world, and that is a more sensitive score to try to find out if the patient has a large vessel occlusion as opposed to just a small vessel occlusion, and that's going to be, I think, prime time in the next couple of years as the EMS people in the EMS companies in the area get used to this grading scale. The hub and spoke model has already demonstrated nationally and internationally that it does take time. It does take time for an ambulance to get ready and get the patient ready from point A to point B, get the patient off of the ambulance rig at point B, and get them all the therapy that they need. And a study recently came out that the median time to get patients from an outside hospital, even to notify that they need help from a bigger hospital, has been 83 minutes. So, and that's the median time. So that kind of highlights the fact that there is a huge delay, even in just communication. Forget about just boots on the ground, wheels on the road. Just the communication can add a huge portion of time. And here's the debate that we have now. So the debate we have now, because we're a comprehensive stroke center, is that do we go for the drip and ship model or do we do the mothership model? And that can really impact how these stroke patients are treated. The ambulance has an option. Let's say you're in Merrimore Park, you're enjoying a Lumineers concert, and someone has a stroke. Does that patient go to Issaquah or do they go straight here? And that is the question where EMS are really struggling with. That's the question that we as providers are struggling with in terms of what is the best option. They could go to Issaquah, they could get their TPA, but what if they have a large vessel occlusion? Now you probably added, an hour and a half, maybe 2 hours for Merrimore, if they can even find EMS to get into Merrimore, to get the patient out there into Issaquah. Whereas they could have just driven straight here on one of the major high roads to get to our medical center or to Harborview and get the endovascular therapy that they may need. So that's the debate, and we don't know what the right answer is. But I can tell you that it is hotly contested, especially in a state that only has 2 comprehensive stroke centers, which is Washington. Florida has like 16 in like a 2-county radius. So it's kind of like we're in a weird situation, and certainly having 2 comprehensive stroke center in a metropolitan area with the traffic situation. Can you imagine if this was a concert plus there was a game at the stadium? It would be a different story altogether. And then I talked about the LAMS and the FAST criteria. So face, arm, great, I understand that. That's a middle cerebral artery stroke. What happens when you have a basilar artery stroke? What happens with those patients? Those patients don't usually come in with just one-sided facial weakness, one-sided weakness on one side of the body, or even speech problems. They come in with a wholly separate set of circumstances and usually symptoms. So these are the kind of patients that, what are we going to do with these patients? How are we going to treat these patients? Should they even be included in these trials? The book that just came out, Emperor of All Maladies, it's cancer, Emperor of All Maladies. I think time is the Emperor of All Maladies, especially, with the current system of, we're all going to get older, we're all going to succumb to just the wear and tear of time. And we had mentioned in that first slide about time being very important, up to 2 million neurons per minute dying. We know that this reflects a shrinking penumbra and expanding ground zero. So how do we push that window of 6 hours? And I had mentioned there are trials now that positive, diffuse 3 and DAWN, which will be coming out, the results will be coming out in the next couple of years, seeing what we can do with patients outside of that 6 hour window. And then what if we could freeze ground zero? What if as soon as you had a stroke, there was something we could do, someone that an EMS personnel could do on the ground when they first saw a patient, recognize that the patient had a stroke? Is there anything that we could do to make sure that penumbra stays where it is and that the ground zero doesn't increase? Well, that's where I think we are privileged to be one of the centers for this new drug called NA1. It is a neuroprotective drug. I don't want to get too into biomechanics or medical things, but I remember this is, I watched a lot of the Fast and Furious films, and so the NOS is, that's what how I think of it, is it's NOS, but it's like bad, and so it's a reactive oxygen species. It causes degradation, oxidation in the body, and NA1 is a medication that we can give to patients at the time of their stroke as soon as possible, in fact, and that slows down the NOS activation pathway or the NOS activation pathway. And so Dr. McDougall is going to be leading this center as one of the PIs for the center here for a phase 3 randomized center trial. And I hope, Dr. McDougall, we're going to get enrolling soon, maybe?
Our optimistic timeline is July.
July, okay. Yeah, so I think that's going to be very exciting for us as the future, and trying to figure out if we can get these patients to get that outcome even better than before. So will we ever get to a point where we use a device and every time it works and every time it gets to 100%? No device right now is guaranteed to give you 100% recanalization or 100% removal of clot. There are new devices out there that are being designed. There are new types of catheter to vacuum clean clot. There are new types of stent retriever that are supposed to capture clot even better. What's also important is pre-hospital triage, like I talked about earlier, in terms of getting patients to the right hospital at the right time. How do we educate our EMS personnel? Neuroprotection we just talked about. The one thing that is hotly debated in radiology circles is how do we image stroke and how do we select the right patients for certain types of therapy. Right now we've been using CT scans and using the aspect scores because it's most efficient, quickest, easiest for people in the community to get a CT scan as opposed to waiting for an MRI scan. All this takes time. But how do we differentiate what is actually ischemic brain, what is actually a true stroke? Will these patients benefit from any endovascular therapy, or will they be okay with TPA alone? These are all questions that haven't been answered. And then there's the last one, like when does it all go bad? And I'll show you a video right now of a patient who, you throw everything at them and you hope for them to actually make it have a difference. Can you log in for me? There's a video of a patient. So this is a patient who is 47. She has a history of diabetes. She just had a inguinal hernia, incarcerated inguinal hernia repair at First Hill. After surgery, they noticed the morning after surgery that she isn't acting right. She's a bit more sleepy. She can't talk as well. And they get a scan, and the first scan shows that she has nothing wrong with it. The head CT looks okay. There's no what they call hyperdense MCA sign or a sign for a big clot in the blood vessel. So they do an MRI scan because they don't know why she can't talk after surgery like this. So do an MRI scan. On the MRI scan, it shows some narrowing of the blood vessel, middle pseudoartery blood vessel. And they presume that this is the reason why she's having a problem. So I will show you a quick video of what just because it shows you what we do in the IR suite and how we can get things done. So Dr. Jalil here has a video set up. So basically, this is what we try to do, and we get a wire. You can see it. And we try to cross the area of clot, and then we have a catheter that also goes past the area of clot. And what has happened is that every time we've done this, and we wait a couple of minutes, it's still going. So we're waiting a couple of minutes to figure out what's going on with the blood vessel, and we take the wire out, and then we take the catheter out. The catheter has actually got aspiration or suction cleaning in it, and we continue to inject dye into the blood vessel. What I wanted to highlight here is this blood vessel. You can see that there's no blood getting any further distally. What we had to do at the time was put a stent in her blood vessel, and you can see the little area of the stent. I can't reach up there, but I'll go back 1 minute or two. So there's better blood flow distally, but there's a tiny little stent here that we had deployed earlier in the surgery. So this patient actually had a thrombectomy, had an aspiration device, but when we couldn't get the blood vessel permanently open, we had to deploy a stent. There is very little data that stents, or probably even less data than I can think of, that stents actually would make a difference in these cases, but this is one of those heroic things that we had to do. If we couldn't get the blood vessel open, we should have had a large middle cerebral artery stroke on the left, meaning that she would never have been able to talk again. She may have even died from it. And this is in the setting of a recent abdominal surgery, so we can't get too aggressive with our blood thinners either. So here we have a patient who lost case scenario, we put a stent up, and she did well with the surgery. She's doing okay now. My gold standard was that she retained a sense of humor after the procedure, and she was able to crack a joke and also understand a joke. So she did fine, but this is the situation where we face day in, day out, where some strokes are not amenable to anything that we do, and we have to get certain measures that are beyond the pale of what we are usually comfortable with. And with that, I'll end my talk.